and requesting all panelists to kindly be very crisp in their comments and remarks. We have around 25 to 30 minutes and we'll be addressing 3 or 4 important issues related to breast cancer, especially in the context of the Centenary Breast Cancer Symposium. So the issue number 1, which I thought is of seminal importance and came up in the discussion today also and before in the conference as well, is that can radiotherapy replace node biopsy? So can I request the radiation oncologist, Dr. Pitanjali, to please address this?
Very good morning and good afternoon, everybody. I think that this question is very pertinent, and yes, it can address the radiotherapy can replace axillary lymph node dissection after positive sentinel lymph node biopsy. I do agree with this because there are...
Okay, thank you so much. So Tanveer, can you please tell us which patients do you consider suitable for these strategies?
Sir, still to start with, I think axillary lymph node dissection is the standard and we are trying to replace it. So it has to be done in a very cautious manner. So I'll be specific for T1 and T2 breast cancer patients with no palpable axillary lymphadenopathy. Only these patients.
So clinically node negative, mostly 1 to 2 positive sentinel lymph nodes. And most of these trials had patients with breast conservation. Do all the panelists agree with these criteria for these strategies? Or is there any difference of opinion?
I would agree, sir.
Dr. Anusheel?
Yes, yes.
Dr. Satyam Desai, being the only surgeon in the panel.
You have the first right to talk. Yes.
Yeah, that's what I was just saying. So the topic itself is very debatable, as you have started with. And there is no doubt about it, as Dr. Tanveer has just said, the standard of care has to be an axillary dissection in positive lymph nodes. And why we are actually discussing this is because of the comorbidities associated with the surgery and radiation, which are combined in the post-operative period. So,
can you please comment on how robust is the evidence? Very important point.
I would not agree with it.
So how robust is the evidence for or against this? So you mean to say that the AMAROS studies and the OTASAR studies that are there, you have a difference of opinion with these studies, and may I know the reason why you have the difference of opinion?
I fully agree with you. Both the studies, the AMAROS and OTASAR, I was just hearing earlier talks. Also, someone had presented it in detail, both the studies. The reason is these studies have been done when we were not doing surgical skills to the tune what we are able to do today. If you would have seen yesterday's video presentation in which we are doing, we are not every center is doing, we are doing lymphatic preserving, full axillary lymph node dissection and reverse lymphatic mapping. With all this, the incidence of lymphedema in times to come will come down drastically, so it will not make much of a difference. That's my opinion on it.
So would we be right to comment that till the time such evidence emerges out in a context of preferably a randomized trial, till that time we are entitled to hold on to this randomized evidence?
Sure, I agree to you.
Thank you so much. So as we know, the data from the AMAROS and the OTASAR study has kind of convincingly told us that we could replace, and in some ways we could also reduce the lymphedema rates. So, but definitely they have said that axillary radiation could be an alternative in such situations. But then I have yes.
Sir, this is Supriya, sir. Sir, just I want to make a point that ACOSM Z11 clearly says that if there is 1 to 2 node positive, then there is no need to go for further ALND.
Yes, we'll come to that also. We'll come to that. Yes, definitely. That's a very important point. We'll come to that. So before that, I have a few questions for my own community, radiation oncologists. So we often say that, okay, we can combine and we can substitute surgery with radiation for axilla. So now my question to the radiation oncologists, and we have very eminent radiation oncologists in our panel today. So the practical question is that in your practice, have you done comprehensive axillary treatment for such patients? And if you have done, you must have combined level 1, 2, 3 and SCF as the target volume And once you have combined all these as the target volume, including the breast area, did you face any planning issues? Do you have any class solutions for beam placements? And what would be your typical dose and fractionation for such patients? So can I ask Dr. Aditi or Dr. Mukti to comment on these very important issues, which are not often discussed in conferences, but will land up into issues when we are sitting at the planning station and contouring and then finally seeing the plans?
Yes, sir. Actually, this becomes very, very important. Though I have not treated axilla and SCF for such a situation, but yes, whenever we treat axilla and SCF along with breast, lung and heart doses for left-sided disease would be very, very important. So planning becomes really challenging as compared to when we don't include the axilla and we just have to treat the SCF. As for the class solution for beam placement, most of the times we try to use tangential beams, but that also the technique would vary from in forward planning IMRT to inverse planning IMRT to VMAT, and left-sided breast tumors, definitely DIBH helps. So there is no one class solution for these tumors because the anatomy would also vary. The extent to which a patient can do DIBH would also vary.
So thank you, Dr. Aditi. And any other radiation oncologists who can add to what
sir. The problem that I see is the dose to the humeral head, and that may be the cause of shoulder restriction in future. If we see the data from MRS also, shoulder restriction is significantly high for the patients who receive radiation, and that is a typical problem that we face. Of course, it increases the lung dose to significant extent also.
Dr. Tanveer, did you have the opportunity to treat such cases? I think his signal is poor. So, Dr. Supriya or Dr. Farhan?
Sir, I just told about the dose to the shoulder joint. I was talking about the shoulder joint dose.
Okay,
that is typically increased. And brachial plexus.
Okay, fine. So let me add to this. I did have the opportunity to treat some cases. I'm not saying a large number, but some cases. And as you can see, this dotted area, it gets added to the breast volume once you start treating axilla, and then you have to combine it with level 1, 2, 3 and the level, the supraclavicular area, and it becomes actually one large volume, treating which poses certainly some challenges. So it's very easy to say that we can substitute radiation for axillary treatment, but practically it does pose some challenges to us as well. And in fact, you can see these low dose areas also climbing up. And not only that, if you see the MROS update, the 10-year update, and it was presented in SABCS in 2018, and maybe not many people have focused on this, but there were certainly more second primaries observed after axillary RTs. The number were not huge as compared to axillary lymph node dissection, including contralateral breast cancers, 21 versus 11. 11 with axillary lymph node dissection and 21 with axillary RT. So I think we also need to sound a cautionary note regarding the rest of the doses that possibly climb up once we treat these larger volumes. Do my panelists agree, or they strongly disagree?
I definitely agree, sir. I want to add another point, that is in the axillary fold, the skin toxicity, and mostly in our hot and humid country, the skin toxicity is definitely an issue. So for that skin reaction, we have to stop radiation for 1 or 2 weeks. So that is another problem we face.
Now, besides, there is another list of questions that remains unanswered with all these trials. For example, questions like, do all the patients, and this was being discussed, I think this question was raised up by one of the panelists. So in light of the evidence from Z11 and MROS, if we combine the evidence and the light that we are getting from these two trials, do all the patients need axillary radiation to all the 3 levels and the medial supraclavicular fields as well? Or can we de-escalate radiation? Would some patients benefit from additional internal memory nodal radiation as well? So these are the questions which really don't have any answers as of now. Any comments from the panel?
Sir, There was a small percentage of patients who did not receive RT even in this trial, around 20% of those patients. So what they have discussed is that maybe the systemic therapy is effective enough to take care of the unaddressed nodes. We don't really know what is acting.
Dr. Abhishek is with us. The medical oncologist, the lone medical oncologist, oh, he's not joined. Okay, fine. So I think we move to the next issue. In the same area, the axilla, how do you address regional radiation after neoadjuvant chemotherapy? And we begin with our dear surgical colleague only, Dr. Satyam. So may I ask Dr. Satyam, because what we do as a radiation oncologist is heavily dependent on what you do as surgical oncologists and what kind of surgery has been done, including addressing the axilla. So our portals and our treatment is heavily dependent on what the surgical colleagues have done. So can you please comment on this broad issue and then we go to the specifics?
Thank you very much, Dr. Anusheel. Regarding LABC and neoadjuvant chemotherapy, basically we have to divide LABC based on a lymph node mets or the primary disease. If it is a T3 disease, we are giving NACT, or we are giving NACT to do a breast conservation surgery. So in our practice and most of the surgical oncology practice, I'll say if we have a post-NACT positive axilla, we are not doing sentinel nodes for those patients. We are doing full axillary dissections. But in certain subset of patients, when we are giving NACT for locally advanced by the virtue of primary disease, in those patients, we still give them option, or we are still more bent upon doing a sentinel lymph node after NACT also.
Okay, so can I turn to my radiation oncology colleagues? Dr. Tanveer is there?
Yes, sir, I'm there, sir.
So Tanveer, can you please take these very, very crucial questions? What do you do with initially node negative axilla, initially node positive axilla, and after chemo has been given in these two situations, what is your approach to axillary or regional RT?
So I will divide the patients whether the patient is patient is node negative, but if the patient is T2 or T3 and axillary negative, the patient has undergone a neoadjuvant chemo, then it becomes challenging. But still, in that case, if patient has taken neoadjuvant chemotherapy, I'll still go and give the radiation. That's one thing. And if the nodes are positive,
no, just a minute. Initially, a node negative axilla T1, T2 patient who has received neoadjuvant chemotherapy. Post chemo
T1, T2.
Would you in any way address the axilla?
No,
say, for example, sentinel has been done, sentinel is negative, and do you want to address the axilla?
No, sir. So T1, T2 and node negative.
So we are all on the same page. Now come to the next issue. Initially node positive axilla.
In node positive axilla.
Now remains node positive or becomes negative. So what do you do in these two situations?
Sir, even if it becomes positive, no doubt you'll go and address the axilla. But even if it becomes negative also, and if it was initially node positive, and specifically if it was N2 and N3, then definitely no doubt I'll again give radiation to the axilla. So I'll address the axilla.
And of course, this approach would be dependent on what the surgeons have done. So again, coming to you, Dr. Satyam, what do you think is the standard of care for sentinel lymph node after chemo has been given? Which cases do you take for sentinel lymph node after neoadjuvant chemotherapy?
As I just mentioned, we are only doing sentinel lymph node after neoadjuvant chemotherapy only in those patients in which we had a proven FNAC negative axilla, ultrasound guided FNAC negative axilla.
Are you being overcautious? Because there is a reasonable evidence, for example, from the Sentinel trial or a SMFCZ trial of N1 nodes post-chemotherapy, and they have demonstrated a false negativity rate of as low as 6 to 7%, provided you are doing at least 3 lymph node dissection, provided you are doing dual kind of mapping, and provided you are kind of doing clipping and chasing that node. So do you think those approaches are not, as of now, a standard of care or not acceptable in our country?
So there are multiple trials going on that you have just mentioned, the Sentina, the SN-FNAC trial, there is a Z1071 trial, post-NACT, there is a clip placement trial, the RIAS trial. So all these are too early to get it into our Indian practice. I'll be that frank with you. For surgeons to be able to change our surgical practice, we need real robust data so that we can change our practice, because it transforms into long-term outcomes for the patients. So I personally don't feel that with a positive sentinel node pre-NACT, I'll be subjecting them for a sentinel node post-NACT.
I think two very, very crucial trials that we have to look forward to: NSIBP 51 Alliance A011202. One which randomizes women with breast cancer who undergo lumpectomy or mastectomy and have post-NAC YPN0 randomized to RNI versus no RNI. And Alliance, again, a very interesting trial. Patients who remain YPN positive on sentinel node after neoadjuvant chemotherapy randomized to axillary lymph node dissection and RNI versus RNI alone. Very, very important trials. And of course, there is one more trial, which is the post-NOC trial, because most of these patients otherwise have gone into the conservation trials and this thing, but post-NOC addresses even the post-mastectomy scenarios, I think, and very, very crucial trials, the evidence we are looking forward to. I now change gears again, and now again, a very, very important issue which has been haunting radiation oncologists for a long time, the cardiac issues related to breast radiotherapy. So coming again to my dear radiation oncologist colleagues, Dr. Supriya or Dr. Aditi, can you take this question? What are the risk factors, especially in light of the evidence that is coming? What do you think are the risk factors for radiation-induced heart disease?
For radiation-induced heart disease, sir, if there is a pre-existing heart disease, if the patient is diabetic, hypertensive, is having dyslipidemias, they're all risk factors, has received some concomitant, some chemotherapy, systemic chemotherapy, which is cardiotoxic, anthracyclines, trastuzumab. These are all the risk factors. And definitely the technique with which we give radiation does make a difference.
Sure.
To add on, Dr. Anusheel, I just may add on that the total dose to the heart, the dose, basically volume of the heart that is involved, the coronary vessels,
of course.
Left side treatment.
Any comments on the pathways study, heart study? Pathways heart study. So pathways heart study came up in the symposium, and it again reinforced the view that other factors such as being overweight are also risk factors for radiation-induced heart disease. Do any pharmacological agents used along with radiation therapy help as cardioprotectives, especially in the view of recent evidence? Any comments on that?
So there are certain drugs that can be tried. I think there are some retrospective data for using AC inhibitors or ARBs or some beta blockers also. There are earlier some retrospective data, some meta-analysis that says that there may be some cardioprotective role. Recently, there was a trial, I think JAMA published the SAFE trial that said if you use both either enalapril plus a beta blocker, that reduces the cardiac events significantly. So these things, but however, there are certain other efforts are being tried, certain other drugs, just statins, certain stress-induced agents. These are all being used. So as of now, I feel the SAFE is the only randomized phase 3 trial that gives some hope of cardioprotective role of these drugs. Others are evolving slowly.
So the evidence from the SAFE trial actually says that maybe these agents help in protecting the heart from chemotherapeutic agents. As far as radiation, actually not much was being achieved by use of these agents along with the radiation. So no benefit actually was happening in patients, especially those who were most important, the left-sided breast radiotherapy.
And so also
patients.
the question is how long
not much benefit was. So long will be another question, but whatever so far is not showing that some benefit is happening, but the length treatment could also be considered. Okay, so radiation oncologists again. Should we be, as radiation oncologists, we have often been kind of very fond of the mean hard dose. As a radiation oncologist, do you think that we need to do much more beyond the mean hard dose, or do you think this parameter is good enough? Dr. Pritanjali, Dr. Tanveer?
Sir, okay, ma'am, please, you can continue, ma'am.
So as far as the mean heart dose is concerned, we were considering that initially, but now there have been many studies which have shown that the left anterior descending coronary vessel, the dose to that also is important to know the atherosclerotic changes and the risk induced to the heart diseases. So we should consider this also as one of the new parameters while evaluating the.
Tanveer, you wanted to add something?
Sir, we should mean heart dose is not only the one aspect. Hello, sir, am I audible, sir?
We can hear you. Yes.
Hello. Yeah, am I? Yeah. So mean heart dose is not only the one criteria. We should start even thinking about that. It's not only the mean heart dose, but even the what is the mean dose to the left ventricle? What is the V5 to the left ventricle? Then like the way the lungs, the pneumonitis is involved, the similar way, like what is the V23 for the left ventricle? So other parameters has to be taken into account, plus also the left anterior descending artery, what is the mean dose? Like left anterior descending artery is basically a serial organ. So even proximal, middle, distal. So all those has to be taken into account. So we should gradually start moving from the just the mean heart dose, because mean heart dose is just a representation of the mean, but where is the maximum dose coming, which particular point, all those can cause electrophysiological defect. So that has to be kept in mind.
Sure. And as you can see, there is critical evidence telling that the distribution of stenosis after radiation very well correlates with the hot spots that we have created during radiation. And at the bottom, you can see the evidence telling us that women who are receiving more than 5 gray mid-LAD mean dose, their odds, their risk for the later coronary intervention significantly increases, especially if they are receiving more than 20 gray, dramatically increases many-fold. So we need to be very sure about other areas as well. Of course, there are issues such as knowing where the vessels are, contouring the vessels, and should we be doing an additional imaging and then fusing it? These are the challenges as radiation oncologists. We ourselves proposed a coronary strip technique. I don't have the details to go into this, but we need to find out our own tools to kind of designate in some way where the coronary vasculature is, so that we can separately delineate it as a separate area and give it to our planning systems. And it's not only the coronaries, it's also that if you go into detail, each substructure of the heart, whether it's the left atrial wall or the pericardium, the right ventricle, left ventricle, SVC area, and all those, and the base of the heart, everyone has its own dose constraints, which we should try to respect. So what are the critical measures that can be employed for cardiac safe radiotherapy? Dr. Mukti would like to comment. Dr. Mukti is there. Dr. Supriya, Dr. Pritanjali.
So the critical measures that can be employed is, of course, cardiac shielding is there, then the beam placements that we have to do. Then we have to contour all the targets, OARs. As you said, the substructure contouring of the heart is very, very important. And as of now, we have heard about the different agents that may help for cardioprotection of the heart. Then we can use those things as well. And of course, DIBH is also one important aspect which we would like to consider when we are treating, especially the left side of the heart.
Thank you so much. So this question is addressed to actually all my panelists, including surgical, medical, radiation. Do you treat the primary with surgery or radiation in patients with metastatic breast cancer? Dr. Satyam, what is your take on this very, very crucial question?
There were discussion on this just before our panel discussion by Dr. Rashmi also. So there are only certain subset of patients with the oligomet, with a single bony met. In such kind of patients, you may consider primary treatment of the breast before starting any adjuvant treatment.
So what approach do you feel is preferable? First systemic therapy followed by local treatment, or local treatment followed by systemic therapy?
It all depends upon the general condition of the patient, the ASA grade of the patient, and how we are thinking that because of the surgery, how much the systemic treatment will be getting delayed. If you are thinking that you will be able to start systemic treatment, maybe within 15 to 20 days, that's what we normally say, we wait for 3 weeks. There are certain subsets we can start at 15 days also. In those subset of the patients, I would think of doing the primary first and then subjecting for the systemic therapy. Otherwise, when there is comorbidities and you are expecting that the post-operative course may not be that smooth, you may subject for systemic therapy first and then considering for.
Dr. Aditi, do you have a difference of opinion?
Then I would always want to give systemic therapy first, because whatever said and done, it is metastatic disease. And only if there is some bone met pain, I would like to give local therapy at that site first and then proceed with systemic therapy.
It will also depend upon the molecular markers of the patient, based on which you may like to take a call. Suppose it is triple negative breast cancer with a single bony met, then you would like to I would personally like to subject for a systemic therapy, not to think of the primary removal in the upfront case. So there are very less subset of those patients in whom you will be thinking of removing the breast or giving the treatment to the primary before starting systemic therapy.
So we already have seen this evidence, the Tata Memorial evidence, the ECOG ECRIN evidence, which has recently come up. And we also know that trials have adopted different strategies for their patients. But the broad outcome that is coming is that, so again, you had the Turkish trial evidence, the EBCSG trial evidence. We have discussed all these things. The big question is that our outcomes, and this keeps on coming again and again, are outcomes for local treatment better if we select bone-only metastatic patients? Now, this is a very, very important question, because even some of the trials have pointed out that in bone-only metastatic patients, they had better outcome for doing local treatment. So what is the take of the panelists on this, Dr. Pritanjali or Dr. Tanveer? Hello. Dr. Aditi?
Sir, it's all about selecting our patients as we move from polymetastatic to oligometastatic, and amongst oligometastatic also we are trying to pick up the more favorable group. So bone mets patients are the more favorable ones. And as data is also showing us, the bone mets patients are doing better. So more aggressive therapy is likely to have more benefit in these patients.
Okay. And some corroborative evidence has come from the MF14 results also, which was focusing on bone metastasis only patients. But have there been issues in these trials? Have these trials been loaded with flaws? Dr. Satyam, you want to say something, or my radiation oncologist colleague want to say something? What have been the big issues which you feel in these trials?
To be very frank, I will not be able to enumerate the fallacies in any of these trials, but for the personal point of view, it is only the bone mets only patients which we are subjecting or thinking of local treatment.
So there was near absent use of Herceptin in the TMH trial. There were higher visceral or overall metastasis in the TMH trial compared to the Turkish trial. There was upfront randomization, for example, done in the Turkish trial. Non-uniform policy regarding local treatment of metastatic disease in nearly all the trials. So what is happening is that we are remembering, for example, in some trials, the local treatment, we are focusing on that, but what is happening to metastatic disease? What is happening to the local treatment of metastatic disease is sometimes being overlooked in these trials. Yes?
Just wanted to make a point, sir. Sir, these all are heterogeneous tumors. Breast cancer, as we know, there is so many heterogeneity. So all these trials are trying to bring all the heterogeneity together. And so if there is a small benefit, that will not be appreciable. And of course, as you highlighted, the therapeutic options varied very widely. And most of the times, just like Herceptin was not used in the Tata trials, the recent developed drugs, those were not also part of the therapy. So there is a gross heterogeneity in the design also and the execution also.
That's what I'm trying to point. So I agree, there has been a non-uniform policy, and that is why we are still at perhaps the crossroads as to what's to be done in such situations. Of course, JCOG 1017 trials are expected next year, so maybe some more light will be shed. So till that time, I present the kind of a consensus. If a panelist has a difference of opinion, they can readily point out. So those patients could be considered for local surgery or RT in metastatic disease who have good response to first-line systemic therapies, good performance status, oligometastatic disease, which again we need to define, and bone-only involvement. So perhaps, and no visceral involvement. So perhaps this small category of patients could be considered for local surgery or RT in the context of metastatic disease.
I agree to you, Dr. Anusheel. There is no doubt about this.
So everyone agrees on this consensus? Great. Yes. And the other thing that, again, I'm bringing this, the SABR COMET trial, because these trials addressed a separate issue. They were kind of focusing on the metastatic disease now. Whereas the previous group of trials were focusing on the primary local treatment. So if we combine these two, perhaps we'll recognize the need of trials addressing, for example, the issue in a randomized setting of systemic therapy alone versus systemic therapy plus primary addressal plus limited metastatic site, whatever is there, aggressive management of all that. So aggressive management of local plus limited metastatic site plus systemic therapy versus systemic therapy alone. Perhaps maybe trials such as these are needed to solve this conundrum. And now final 1 or 2 minutes only, we are left with very little time. Does anyone in the panelists feel that is breast radiation based on molecular markers ready for use in the clinic? Aditi?
Sir, as of now, we are still relying on the T stage, the nodal status. We do not take our decisions based just on the basis of.
So there are a lot of trials, evidence coming on, but still, I don't think we, any other panelist has any opinion? A difference of opinion other than this? So why are radiation oncologists still unconvinced? Pritanjali, you want to say something?
So there's not much data to suggest that if we can, just look into the molecular profiling as we do for the sake of chemotherapy and everything. So we need more robust data coming in.
So one is lack of randomized evidence. Then most of these trials which have been done, they have adopted an all or none approach, which perhaps is either you give radiation or don't give radiation. But there could be situations where a low dose or a higher dose of radiation is required, or the volume of the area that you need to treat needs to be tailored, and most of the trials don't address these issues at all. And of course, there are various dilemmas, for example, that keep on coming out in this very important trial in which 21 gene recurrence score was assayed in JNCI in 2017, often quoted and repeatedly quoted. So while in the overall group analysis, the recurrence score correlated with the locoregional recurrence, but then if you separated them out, 1 to 3 nodes and more than equal to 4 positive nodes, paradoxically, the recurrence score was holding well for more than equal to 4 positive nodes rather than the low risk group of 1 to 3 positive nodes, which is quite paradoxical in a way. We expect evidence to come first for the low risk group of breast cancer patients to guide us what we have to do in that. High-risk patient, I don't think anyone would be taking that much risk of not giving radiation to a patient with 4 or more positive nodes. But then again, this is a kind of a counterintuitive result that has come up in this study. So what is the way forward? We need to look forward to these trials. Again, most of these trials have focused on a low risk. If you see, they are PT1 and zeros. Most of these trials are PT1 and 0 patients, low grade patients, a low risk population, which is being randomized. So still we are trying to have a hold on what's happening to the low risk population. And once we have evidence from this, then only we can consider a higher risk population. So as radiation oncologists, I feel, and this is the way I could sum it up, the need of the hour is this whole group of patients, which is there on the left side, which we either treat by radiation, or as of now, we either treat them with radiation or we don't treat them. That's the only decision we make. Either I'm giving him radiation or I'm not giving her radiation. So by means of molecular testing, if we could split them into patients who require more radiation dose, standard radiation dose, less radiation dose, or no radiation at all, and also preferably tell us about what is the fractionation that I can use, what is the need for regional radiation, and how much the treatment volume should be. And that, if molecular analysis tell us, I think that would be really, really beneficial to all of us. With those words, thank you all for being in the panel, and thank you organizers for organizing such a wonderful scientific event. Thank you.